All right, so I think we should get started. I'm not exactly sure where Dr. McNeil is. This is part of our Academy of Master Educators Faculty Development Series, a rotating series of topics where we bring in people to share their perspectives on your teaching role. And I think we have a nice slate of people this year. And our topics are designed to appeal to different types of teachers, and we have a range of people in the audience. And I think this is a great way to get us charged up for new ideas, new ways of doing things. And I think our new way of doing things today is actually a very old way of doing things that has fallen out of favor for different reasons that we want to try to reinvigorate and get back on track. And it's the idea of a chalk talk. And to help to share a little bit about what that means and how you might use it in your teaching, we're very fortunate to have a master in the art of the chalk talk, Dr. Jamie Tu. Jamie's a longtime colleague of mine in the Department of Psychiatry, a graduate of this medical school, who came here for residency and stayed on as faculty, and many of you know him. He's an award-winning educator, and he's known among the students for really excelling in this art of the chalk talk. And I'm really excited to hear what he has to share with us today. So please welcome.
Okay, thanks. And in fairness to Jason, he has no idea what I'm going to talk about today because I didn't share anything with anyone until I'm handing out this handout to you guys right now. Okay, so take one and pass it around, but try not to get too fixated on it. One of the things about doing chalk talks, which is essentially presenting to a group without slides on a given topic, is that you try not to compete with your own material, as we often are doing with PowerPoint. So I'm going to ask you in this, you can refer to the handout, but for the most part, try to keep it up here. We'll get through this together, I promise. I want to start just by understanding the audience here. So how many of you lecture to first or second year medical students? Just raise your hand. Okay. How many of you will present information or lecture to third or fourth year medical students? Most people. Okay. How many of you have given a lecture to a large group of medical students, say the full class or something, lasting at least an hour, 45 minutes to an hour, with no slides? A couple. Have any of you given lectures lasting to anyone, lasting up to an hour without doing PowerPoint? Okay, most of you. All right. So you already have experience in this area, so I'm just a non-expert who's going to share some of my reflections on giving talks. First of all, I would say, doing a presentation without slides for some people is scary or intimidating because it feels a little bit like a high wire act, right? What if I lose track of where I am? What if I lose the audience's attention, right? What if I go off on a tangent? Or what if I have nothing to read when I'm going through my information? And that's why with chalk talks you are going to need to practice, and you're going to have to challenge yourself to build a narrative when you are teaching, okay? That is what is going to keep you on task. That's what's going to keep the audience able to engage with you, okay? And so a chalk talk where you're off of PowerPoint looks and feels a lot more like a TED Talk, okay? So who here has seen TED Talks? Do you guys have what's your experience with those? How do you come across them? Somebody recommends, oh, you should see this TED Talk on something, right? Do you guys have a positive association with those? Are they generally as a good TED Talk? Do you feel it's a viable way of communicating information? It generally is. So what do people do in TED Talks that's different from lectures? Well, a big one is they tell a narrative, all right? And they usually build themselves into that narrative, and they impart information through this storytelling. Oftentimes it involves them. I would argue that med school education is really well designed for this kind of a format, because these are professional students. They're hardworking, and they came to medical school in large part because they want to be physicians and they want to be good at it, all right? And one of the ways we engage them is by being that role model, right? And showing them how the information we impart affects us, affects our patients, and is going to affect them in the very near future. And that allows you to get some emotional engagement or buy-in so that they follow along over the course of the next whatever, 20 minutes, 40 minutes, what have you. So that's one way that chalk talks are different. You're telling a story and embedding your information within it, as opposed to a PowerPoint presentation where information is the star of the show and you're more kind of pointing to the information, okay? I would argue that in order to do a chalk talk, you need to have a hook, all right? This is very much like a TED Talk. Good TED Talks are engaging because the presenter does not take the audience's attention for granted. There is not an assumption that just by virtue of the fact that you're sitting in front of me, I'm entitled to your sort of caring about what I have to say. It's important to recognize that by the time, say, a third-year medical student is sitting in a lecture with you, they've already been through something like 40,000 hours of lecture-based teaching. Does that sound like a high number? Are you surprised to hear it? 40,000 hours? I just made it up. I have no idea if it's true. But it sounds plausible, right? One of you is like, no, that sounds plausible. That's disgusting, right? That I can even say that. What that makes them is experts in thin slicing, okay? In a Malcolm Gladwell sense, they're determining in the first minute that they sit down whether you're worth listening to. They really are, okay? And if you don't offer them some kind of hook or engagement, they're going to start desperately looking for information elsewhere, right? Through their syllabus, online, this kind of thing. They're going to start getting anxious and thinking this is a waste of my time and calculating the opportunity cost of being in your presence, okay? So how do you hook a medical student? You start with their favorite subject. What is every medical student's favorite subject? Themselves. Themselves and their anxiety about whether or not they're going to be an adequate performer, all right? This is a thing that they could talk about and think about their entire lives, okay? So you build that in. The place where I do where I do my chalk talks is in the first year of medical school. It's at the end of the first year, and I have to give like 2 hours of lectures on psychopharmacology, an hour of lecture on psychotherapy, and then... Now, at the end of first year, and there's only 2 weeks to go before their school year is done, they've been sitting in LR, whatever number that is. I sat there. I don't remember. I blocked it out, right? LR 6, 4? LR 4. Thank you. Thank you, Amy. LR 4 for a year. Also, what percentage of these students are going to go into careers in psychiatry? Fewer than 4%. In a good year, 4%. All right? So now I'm coming in. It's the tail end of first year. These people are exhausted. And fewer than 4% are likely even going to go into my field. How do I engage them? Well, the first thing I do is I have to make them aware that this is relevant for them. So I tell a story. This is how I open up my talk. You know, I went to Pitt Med, and when I was a third year medical student, in my first day of third year, I was assigned to orthopedic surgery as part of surgical subspecialties. Now, I'm rare in that I was a doctor. I knew I was going to be a psychiatrist when I went into this field. Most people don't know that. And the orthopod, it was James Kang. I think he's still here. He's like, what do you want to do? That's a default question you will always be asked. And you're going to have to figure out how to deal with that question, right? You get different advice on how to handle that question. Some people say you never acknowledge what you really want to do because you don't want them to tune you out, right? But I didn't. I didn't know that. I said, I'm going to be a psychiatrist. You know what he said to me? He said, I prescribe a lot of antidepressants. I was like, you're an orthopedic surgeon. What do you mean? He said, I said, you do spine surgery. Why are you prescribing antidepressants? And he says, think about who I treat. This really happened. Every day in clinic, when I'm seeing patients, I see people who are in chronic pain, disability, right? They're exhausted, they don't sleep well, and to the point of letting me cut into their back. There's really high rates of depression in my practice, and a lot of them don't want to go see a psychiatrist because they go, I'm not like mentally ill, I have a serious problem and it's getting me down. So they want me to provide for them. And every rotation I went through in my third year, I heard this over and over again. Pediatricians, family practice, just about every surgical subspecialty, OB, I prescribe a lot of antidepressants. So if you're going into psychiatry, you can walk out right now, right? Because you're going to get this over and over again. It's for all of you that aren't going to psychiatry, you need to pay attention because you're not going to get a lot of teaching on this and you're going to face it every day. I can guarantee you that in the first week of becoming an intern, you'll prescribe 2 classes of medication, an antihypertensive and an antidepressant, guaranteed. No one's ever come back to me and told me I was wrong, all right? So that's it. That was a 3-minute narrative. And what I had to do, my task there, was to take the future orthopedic surgeon and get them to think, damn, I better listen to this lecture on psychopharmacology, right? You have to flip that. I never felt entitled to that person's attention, okay? So that's an example of a hook. It involved a story, placing myself and humanizing myself as the speaker, getting them to identify with me, citing and making relevant their anxiety about their practice, okay? These are all the things that are necessary. And you need to think about this in giving any talk, even if you're using PowerPoint, because they're deciding in those first few minutes, am I going to get anything useful here? The next thing, so that's the hook. The next thing, explicit scaffolding, all right? Scaffolding is critical when giving any kind of new information. That's basically just telling people that you're giving them a structure for organizing and retaining the information, okay? And you're very explicit about it. So when I do this, I say, now I'm going to give you an organizing structure for this information, okay? It's not, don't make it implicit, don't have them figure it out. What am I communicating on a meta level when I say something like that? This is going to be high yield, right? And that's another thing that medical students are seeking out, like, they're programmed to look for high yield information, and I'm showing them respect right now. So what I do is I say, for example, in my psychopharm lecture, I go, when you approach psychiatry, psychopharmacology, you first have to just understand that we cluster the field into disorders. And our job is to diagnose what form of disorder is this person suffering with. So for example, in general medicine, we do a thing called differential diagnosis, all right? A person doesn't come in and say, I have gall pain that is exacerbated when I eat fatty foods, right? They come in and say, my stomach is killing me. And we go, okay, let's focus in on this area. And then we learn organ systems and think, what's going on in there? What could be happening? So maybe it's down here, maybe it's genitourinary pain, right? Maybe it's in their colon or something. Maybe this is more gastrointestinal. Or wait a second, could they have been shoveling snow and they tore a rectus muscle or something? Maybe it's more musculoskeletal. Or maybe it's upper GI. Maybe this is something, maybe they're having some kind of pancreatic or biliary problem, right? And you say, and then what we do is we ask a series of questions and we perform exams and sometimes draw labs to rule out and rule in different diagnoses, right? This is how we practice medicine. Well, in psychiatry, it's no different. People come into us and they say, I don't feel right. I feel bad. Or I'm having thoughts that if this is what life is going to be like, I don't want to live anymore, right? And then we need to figure out what kind of behavioral system is disrupted. And these are the systems we look at. We look at basic disorders of mood and mood regulation. We look at thought disorders or disorders of perception, right? And cognition, thoughts and perceptions. We may look at disorders of anxiety, right? This is your organizing structure. And within mood, there's two spectra that you need to be concerned about. When people's mood is too elevated, what do we call that? Pathologically elevated mood. What do we call it?
Mania.
Mania. You know this. You're not psychiatrists, but you know this. What about the lower spectrum? What do we call it? Depression, right? And within this, we have psychopharmacology now, all right? There are interventions to treat this. All right, so I'm going to break now. So, and then within, actually I'm not going to yet. so now we're going to talk about psychopharmacology. We use mood stabilizers, and this is logical, right, to treat this. And within that realm, there's two categories, all right? There's lithium and anticonvulsants, all right? There's about 3 anticonvulsants you're going to need to know, and there's lithium, and those are in separate categories. And we're going to review those, okay? And you go through and then within antidepressants, I want you to think of it this way. There's old and there's new. There's old antidepressants that were first introduced in the 1950s and 60s, okay? And there's 2 types you need to know. So old and new, all right? And then you break it down, and you literally write it out for people, okay? Now I'm back talking to you all now, all right? So this is the scaffolding, okay? Do this for people. Make it explicit. It forces you as the teacher to think about how do you want the learner to organize this so that they can remember it. Trust me, if you give them scaffolding, they will be able to recall it later, all right? If you don't give them scaffolding, if you just jump right into content, they will not be, it's hit or miss whether they come up with a way to organize it, and they'll also waste a lot of energy trying to come up with an organizational structure that you could give them in 2 minutes, all right? Now, some people struggle with this. Some people feel like this is spoon feeding, right? Oh, we shouldn't spoon feed for them how they learn the information. I don't care, right? If I'm 15 years out and I've learned a strategy to retain information and make it meaningful and allow you to use it, why wouldn't I teach you that, right? Why wouldn't that? And some people also worry that this takes time, but the payback is huge. If I invest 3 minutes in giving you an organizational structure, everything that comes after that is going to be easier for you to retain and understand. So pay the time up front to do your hook. Pay the time up front to give an organizational structure, and then put information inside of it, okay? All right. So that's explicit scaffolding. Retaining audience attention. We talked about you're not entitled to get it. Do not feel entitled to keep it for more than about 7 or 8 minutes, even if you won it the first time. This is 2016, okay? You have no idea what you're competing with. So even if you're giving the best lecture of your life, you cannot compete with somebody who gets a tweet from Donald Trump saying, like, burn all Muslims, America is great, it's rigged, right? That's going to activate them. It's going to draw their attention into their phone, and they all have phones, okay? So what you need to do is every time you shift a content area, get people back on the bus, all right? So, and be explicit about it, right? So far, we've talked about how Chalk Talks are different and how they're more like TED Talks, and you have to hook people's attention. And then we've talked about the importance of scaffolding, explicit scaffolding, and how it's worth the time. Now we're talking about getting people back on the bus, okay? Everybody that's been distracted, start up with me again now, okay? Be explicit about it. So that's what I did right there, was getting people back on the bus. Some of you checked out on me, right? And I said, this is the time to get back on board, because if you checked out in the first 5 minutes, that doesn't mean you should be out of the game for the next 45, okay? That's really important. It's courteous to do that in 2016. Peter, do you have a question?
Just a question.
Yeah.
So, sometimes people start writing, and I always think that's sort of distracting for the learner, although they're
Yeah.
sort of. And then other people actually take pictures of the board.
Right.
So when you wipe it out, you can actually give people the opportunity, or have a large board and leave it
Yeah.
there. I just was trying to discourage people to write it down, because then the interactive part sometimes gets lost.
Right. Actually, you saw me do that in the beginning, where I gave you a handout and then dissuaded you from attending to it too much, and tried to reassure you to some degree, this information is going to be in your handout. Right now, I really just want you to attend to what I'm saying to you, okay? But yeah, people are going to do all sorts of things, and so you need to recapture their attention. Yes?
That was advocate. I think there's studies out there that if you actually take physical notes, you remember stuff better.
I am a copious note taker, all right? If I'm sitting and getting anything, even in meetings, like administrative meetings, I don't have it with me, but I have a spiral bound notebook at all times when I'm in meetings. I almost write down like a stream of consciousness, what is going on in the meeting. I almost never refer back to it, but when I do, it's helpful, but I think it's how I process information. So everybody's going to do it their own way. I just need to make sure that they don't go off into la la land, all right? So I would argue that it's courteous. Oh, see, I was supposed to leave out my hook, scaffolding, right? Because this is our path, all right? And then again, getting back on the bus. So you will need to do that probably 3 times in the span of a 50-minute talk, all right? You are going to have to get people back on the bus. Again, it's just courtesy in 2016. It's just acknowledging that people's attention is going to be pulled off, and a courteous thing to do if you expect to maintain 50 minutes of attention in this day and age is to give people opportunities to return to you, all right? Okay, here's one. Can you draw? Who here thinks that they can draw? Raise your hand if you, yeah, we've got somebody who's willing to say, I can draw. I can draw basic things. None of you think you can draw? All right, this is really good then. Okay, you said I maybe can draw, right? Yes, it's not exactly grandiose, right? So what I would then challenge you to do is, if you're giving talks, like all of you teach third-year medical students, right? Do you teach on rounds? Is that what you do? Is that the format in which you do it? Well, if you ever have the opportunity, think about the organ systems or the kind of the content areas that are relevant to your practice and learn to draw basic cartoons, even just 4 or 5 of them, all right? So I'm a psychiatrist, and I'm a geriatric psychiatrist, so I do a lot of something that's more like on the lines of neuropsychiatry with people that have degenerative syndromes. So whenever I'm talking about dementia, I always draw a brain, right? And then I always do this. I always go, hi, right? So what I'm doing, right, that's so you know which way the brain is facing, right? I'm looking this way, so that's the front of the brain, right? There's a reason to do this. One, if you draw simple structures, you're forcing yourself to boil down the message, okay? Again, this is a challenge to you as a teacher. If you only have 10 minutes in rounds and you want to present content, how are you going to package it so that your learner can take that and then move forward from there, right? So learn to draw simple things. I say, this is the frontal lobe, this is the parietal lobe, this is the occipital lobe, and this is the, what is it? Temporal lobe. We know this, right? So, and your brain floats 1 foot above your head, right? No, but and I talk about, Alzheimer's disease. It starts here in a structure called the hippocampus, right? Really important for new learning. Okay, new learning and storing new information, right? Frontal dementias are different, though. They usually have 2 flavors to them. There's the orbitofrontal cortex, and this is associated with disinhibition. Notice that implies that inhibition is normal, right? And it is, okay? We should be socially inhibited. It would be weird if I walked up to people and just started doing things, right? It would be intensely uncomfortable, right? And that's another point that I'm trying to make. When you're giving a chalk talk, you're not rooted to a podium advancing slides. You're now free to move. And just like you need to inject novelty with drawing, you need to inject novelty with your behavior, okay? You need to make people at times a little uncomfortable. Demonstrate things, okay? This is an opportunity to keep people attending to you. All right, so coming back to, that comes up later when I talk about communication cheat codes, but don't jump ahead, Amy, and read about it. Okay, so draw a picture. Another one, where did you already see me draw a picture, right? When I was trying to explain the basics of differential diagnosis, I just drew a little person, right? Again, injecting novelty and simplicity. This is intended to be sort of inviting. It says, I am not going to overwhelm you with information. I'm going to explain this to you at a level that you can absorb, because oftentimes a chalk talk, look, a chalk talk is not going to be an opportunity to give people the micro minutia of a subject. I used to have a mentor at Western Psych who told me when I was a medical student, he was my research mentor actually, he said, all through medical school, and this was a great strategy by the way, whenever you're going to read about an area, first just pick up the Merck manual. Do you guys remember the Merck manual? For those of you, this was before like the interwebs and that kind of thing. There was a guide, it was almost like the Fred Ferry pocket guide or something, but it was a little bit more robust than that. On any topic, this little Merck manual, you could read about 3 small pages. He said you always start there. Then you move to Harrison's, right? And then you move to like actual articles from the field. If you start that way, each time, like the Merck manual will boil it down to basic concepts that will give you 80% of what you need to know and probably about 50% more than anyone else knows, right? Then you read Harrison's, and Harrison's is much more accessible now, right? Because you've already seen some of the big words and it's been boiled down for you. And then you access the literature and with the whole kind of framework already in place. And chalk talks are the same thing, okay? It's like that first step of reading the Merck manual. You do this, and then you say, you use the terms and the vocabulary, and then you say, so now I want you to read this chapter of this textbook on neurodegenerative syndromes, okay? This is not your ending point. This is your welcome mat to information, okay? All right, so can you draw? I would argue if you think you can't draw things, you're probably raising the bar too high for yourself, Okay, so I just want to, yes, go ahead.
Oh, I just have a comment. So some of my drawings take a little bit of time. So what I do is I go and I draw it before.
Yes.
And I leave it there. Like I go like 20 minutes before and I draw it. So it doesn't take time out of my,
Absolutely.
my speaking.
And I do something too. So for example, and I'm just going to use my psychopharm lecture because it's the it's the largest content chalk talk that I do. One thing is we have a table for explaining like the dopamine pathways in the brain. I'll come to the lecture room, LR whatever it is, a little bit early sometimes, and I'll just put in the table already, and then during the course of the talk, I will fill it in. You've got nigrostriatal and tuberoinfundibular and mesocortical whatever. And then you have like what's wrong in schizophrenia, then you have what the medication is going to do, right? So, it's up and then down or whatever, okay? So you may want to do some prep work. If you get really good at it, you may be able to draw it quickly. And again, seeing you draw is stimulating for people. Okay, it engages their brain? Their right brain a little bit, right? It's just novelty. Remember, after 1,000 billion hours of this, novelty is appreciated. Okay, it says I took a little bit of time. Okay, I thought about this for you. All right. Other questions about drawing? Yeah.
I have a comment. I can't draw. But I sometimes do draw, and I always say I am actually the world's worst artist.
Yeah.
And it's true. And everybody recognizes it's true. And I actually think that may be somewhat effective.
Yeah, so what have you done when you do that, by the way? So I'm going to wear my psychiatrist hat.
Separated myself from being the expert in everything.
Correct. You humanized yourself, right? That you gave yourself a little bit of vulnerability, right?
Not actually admitting to any deficiencies in
That's right. That's right. I'm not asking you to be right. You don't say, I am a horribly limited person. Right? There are so many things that I don't do properly. Allow me to demonstrate. It's not, but remember, this is about engagement, right? And this is medical school. They want to learn to become physicians, and you have to pack information into that journey rather than, nobody said, I really want to learn information, right? I really just want so much information, right? They want to be doctors. And what you're doing is you're even being a little bit vulnerable to them. And that allows them to think, that guy's like me, right? Maybe I can do this, right? And so I'm sure they appreciate that. A lot of it is just, does your audience respond to you, Okay. So now, practice. This is really important if you're going to be giving talks, whether they're 10 minutes, right? Whether they're sort of discrete packets of information that you want to use as a stepping off point for your students. Let's talk about how the pancreatic islet cells manage blood glucose levels, all right? I'm just going to draw you a pancreas, and there are these islet cells on it, right? And when they detect high levels of glucose, whatever. I have no idea what I'm talking about. I haven't thought about this, and that was on the fly, and I'm starting to get really uncomfortable. So, but you do that. It's a 10-minute topic, and then you stimulate them or you challenge them. Why don't you go read about this on Up to Date tonight? Because Karen here in room 1222, this is a struggle for her, right? This glucose regulation thing is really hard for her. All right, whatever. So whether you're doing 10 minutes or 1 hour, you should practice this in front of a candidate learner, not your spouse. How many of you practice big talks in front of your spouse before you do them? I used to, but I've been married for 17 years now, and I know she doesn't care. Right? She is she is just straining to appear to pay attention, right? And she's a physician, my wife, right? But she could care less. So now what I do is when I have a student that I'm rounding with, I try the chalk talk on them. The day before or a week before or something like that. Or on rounds, I've been kind of slowly growing one, and I've been kind of tooling it as I go. So I would recommend, and then once you have a chalk talk in the can, it's like a performance, it's a routine that you do, I recommend that if you haven't done it for a while, practice it in your office beforehand, right? You are literally talking to yourself, okay? So make sure the door is closed, the whole deal. And walk through it, because there's nothing worse than trying to do one of these high wire acts, like an hour or 2 hour long talk with no slides, and realizing that you're rambling and you're forgetting where you're supposed to go, right? And so, so I would say practice, but not in front of your spouse. They don't care. All right. They won't give you very good feedback. Yeah.
Do you ever have like a handout with you, like for your, like a cheat sheet with you?
Yeah. Do you notice what I'm doing? Your handout is my cheat sheet. And it's keeping me from getting lost because I'm experiencing a micro crisis at the end of each content area. All right? I'm literally, that's what's happening. When you see me do this, I'm like, what now? Oh, God, right? I've never given this talk before. I've never, Jason has tried to get me to do this a few times before. He invites me to talk with the residents and he says, Jamie's going to talk about Chalk Talks. And I come in and I just kind of ramble, right? Because I haven't really wanted to make any of this explicit for myself. I just do this stuff. This is the first time I've really, and it's because of you all, like I was, with the residents, I don't care, right? I can get up there and just, whatever, scat for a while. But you guys, I was a little more intimidated. So I thought I better at least think about what this means, what I'm doing. All right, so yeah, I do. I refer to this, okay? And that actually, so now let's talk about the syllabus. Oh my God. So I heard you guys just had to talk about the syllabus. My first line is, don't you dare F with their syllabus. Okay? There are certain levels of hell, right, that are reserved. There's like rapists and murderers, but beneath that, there's people that commit genocide. And then there's the attending who had a bad syllabus. Like, there's nothing, you are such a deplorable when you mess up with their syllabus. So, and yet, year after year, we see in our syllabi just crap that doesn't make sense. I had to learn the hard way, okay? I got feedback that my talk didn't match my syllabus, and I got hammered for it, right? And I had to swallow hard, because there's a part of us that's like, screw you, Screw you, like, do I really have to spoon feed you? Like, pay attention. How about that one, right? And also, it's kind of like doing your notes as doctors. We feel like the real meat of the thing is how do we engage the patient, our medical decision making, that kind of thing. Then we have to go back and write a note about it, and we're like, oh God, and our notes aren't always that great, right? But the problem is, all the students care about at the end of the day, like if I shoot 3 people on Fifth Avenue, but it was in the syllabus, well documented, they're like, I'll give you a pass, right? So you have to respect the syllabus, okay? You are seen as uncouth and disrespectful when you don't prepare your syllabus. So what I do in my Chalk Talks is I basically try to write out what I am conveying in my Chalk Talk in the syllabus. And I don't know, Amy, I don't know if I had done this at the time that you were coming through as an MS1 or not.
I mean, all I can say is that I think most of us that went to PittMed thought that whatever you did, it must have correlated with the syllabus because we were all very impressed.
Okay, all right. So I may have been castigated and flogged already by that point because now I try to have my syllabus almost exactly mirror as I go through the lecture. If you were going through my syllabus, it would just flow. Again, this is about being respectful to the learner, and for whatever reason, this is critically important to them, and so it's critically important to me now. All right, and you guys have to. We have to come to terms with that. All right. Now, communication cheat codes. This is good. I'm going through this much more quickly than I thought because I want to do an exercise if we have time. I want us to start thinking about what is it that we do as Chalk Talks, and if you think that the stuff you teach is too boring for a Chalk Talk, we're going to work that out in sort of a group therapy. Okay, all right. So now, communication cheat codes. One is called the standard, and this doesn't matter whether you're doing PowerPoint or whatever. Who here has heard of the standard American melody of speech? That's interesting, right? I hadn't heard of it until I was flipping through On Demand on Xfinity, and I saw this documentary called Do I Sound Gay? And I thought, I'll check that out. So I watched it, because, that's interesting. So, and in it, there's a guy who believed that he sounded gay. And so he did a documentary of himself trying to learn more about what is it about our speech characteristics that either sounds or doesn't sound gay, all right? And so he met with speech experts, and they talked with him. In one of the segments in there, he met with a speech coach from Hollywood who talked with him about the standard American melody of speech. Now, the standard American melody of speech is you kind of know what it sounds like because most people in positions of authority in Washington have adopted this strategy. It's basically how people who know things communicate to people who are supposed to hear things. So listen to the way I'm talking. I have pauses, right? And I finish low, all right? There's something about that your brain starts to think, I'm getting something good, or this is important, all right? And so I want you to think about whether you see how I'm continually finishing down? And when you finish down, it sounds declarative, it sounds confident, it sounds like you know what you're talking about and now you should listen, okay? So think about how you speak. I naturally started communicating this way probably because I saw examples. I used to be very interested in public speaking. And I used to study public speakers. How do people that I'm responding to and that the audience responds to, how do they communicate? And this is something I figured out. And so when I learned it's called the Standard American Melody of Speech, I was like pleased to realize that's a thing, okay? So I want to give you an example. If I say, I think there's a real problem here. Obama, I don't think he was born in the United States. How does that sound? It sounds hysterical. It sounds like kind of freaky or, like this person's off their rocker. But what if you say it like this? Guys, and this is hard for me to say, but I think there's a problem here. The problem is, as I'm looking into it, I believe that Barack Obama may not have been born in the United States. Now, how does that sound, right? If I'm finishing down, I'm talking, you're like, geez, what if he wasn't, right? For some reason, it's a cheat code. I'm just saying the same ridiculous thing, but I'm saying it in a melody that sounds legitimate, okay? So I would ask you to think about how do you communicate, right? I think actually Hillary Clinton had to switch over. I don't think this was natural for her, but if you look at the debates by the end, she was doing this more regularly, right? Because people were giving her feedback. You're not hitting home. You're not connecting. Whatever. I don't know, right? So that's one cheat code. Think about that. I have one colleague that when he communicates, it's sort of like I think about ways people, it's more like yeah, 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 yeah. Yeah, 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 yeah. And I think, why do you do that? Because the stuff he's saying actually makes sense. But everything about the tone says, don't listen to me. Right? Just, you don't want to hear this. Right? So think about that. All right. Another one. Okay. I think I have another cheat code in here. Oh, use of humor and irreverent humor. This is when you're doing a chalk talk and you're a little bit, and you're moving around. You notice I'm injecting a lot of humor into this talk. This is important, all right? Humor will engage people. And the more you're doing a chalk talk that feels non-traditional, the more you can get away a little bit with irreverent humor. Irreverent humor is a tricky one. But if you use it, you can keep people engaged and feel like they're getting something good, all right? But you can really screw up with this one too. So my tips for you when using humor and joking around while you convey information, there's two rules. And I think I already kind of violated a couple of them. But one is self-deprecating humor is always good, right? I think you pointed that out, okay? I can't draw, but this is going to be horrible. Like, I'm going to draw a pancreas now. Oh, God. Yeah, right? Yeah. That's okay. So that's always a safe zone, making fun of yourself. Making fun of the day-to-day situations you find yourself in as a practicing physician, okay? Another one that's generally, what's another one that's okay? Oh, what's not okay is ever making fun of a patient. All right? We all have our gallows humor at times, behind closed doors with our colleagues, as a way of diffusing our own frustrations or tensions. We say things that we're not always proud of, but we're dealing with frustration, and we say sometimes cynical things, right? Do not say that in front of learners, okay? Or try not to, because you will alienate them. All right? You will potentially demoralize them, and very worst, you'll be a role model for cynicism, right? So you can do it a little bit more on rounds. The culture of gallows humor and cynicism is a little bit more culturally kind of at times seen on rounds, or it's just harder to control, really. But cynicism in a talk where you're trying to inspire is toxic, and you will alienate people. Another one, and I kind of violated it, but I did it for a cheap laugh, was and don't characterize other people as stupid, right? So we have this really bad habit in medicine. I mean, medicine is a large field. We tend to bash other specialties, So surgeons say internists are obsessional and miserable, and internists say surgeons are idiots and lazy. I don't know what. Like, we do this. Don't do that. You will alienate your audience. One, because you don't know what specialty they align with, and you may simply be offending them, and they hate you, right? And also because you don't want them to be doing that. Okay? So when you use humor, self-deprecating is safe. Ever making someone else feel dumb, or ever making fun of your patients or looking down on your patients, never really okay. Okay? All right, so those are my 8 tips, and now we do have time for us to have a discussion, and maybe even, I don't know, I never thought I'd get through this quickly, right? But I want to know if you guys have, first of all, what are areas where you've done chalk talks, or areas where you feel you could be experimenting with doing them? Because what I think would be good for people is try to develop 3 or 4 of these things that are in the can, that you can trot out at any time, all right? When there's dead space in rounds, there wasn't as much to see, you got through rounds a lot more quickly than you thought, and you think, this would be an opportunity for me to go into the break room, stand up by the board and say, today I just want to talk with you a little bit about antipsychotics and some of the neuromuscular side effects or adverse effects that you might see when you prescribe them, okay? And this is really important because 2 days ago we saw Betsy Smith, and she had a dystonic reaction. So let's talk about that, right? So if you can develop a few of these, your students are going to love it, right? You can use that as a launch point for more robust learning off hours, right? You do your chalk talk, you talk a little bit, and then you send them off to read, okay? And also you may find as you do chalk talks, people will see it and you'll get invited to give them in unexpected settings, okay? So I give the brain chalk talk I give, I've been asked about, where I do 4 major subtypes of dementia in really simple terms. I've been asked to give that for nursing students, PT students, undergraduates, communities. It can be fun, actually, when you boil something down to a very absorbable and accessible piece of information. It also is exportable to non-medical school environments, and that can be a lot of fun. Okay, it also helps grow your reputation as a teacher, right, for the community. All right, so let's transition now. Who here does chalk talks on a regular basis? Okay. Can you tell me a little bit about your experience and whether some of these concepts resonate with what you do, or do you have a different take on it altogether?
My chalk talk is I usually do hyponatremia.
Okay.
That's like the one that I almost do at least once a month, and the issue is that I have to do a basic physiology review before I do the hyponatremia talk. So. I don't necessarily start with the hook, but I think it's something that I might incorporate in my chalk talks from now on. Like try to give them the story, and I have a couple of stories, and just try to make them engage. But the rest of what you explained, basically, I didn't know that I was doing it, so I do the scaffold with them. But I think I should point it out, and I'm going to give you a structure. I don't explicitly say that before I do that, and I do some jokes as well, so I think I'm there. I think the hook was very interesting for me, so I'll start doing it, I think. So.
And you may have a little bit better hook because your audience may be much more primed, right? If this is a small group on an internal medicine rotation,
right,
they may be primed because they feel they have to know hyponatremia right away. Another hook I use is I tell people, this is probably going to be on your exam. Right? And all of a sudden they like, what? All right. Yes?
So to me, one of the big advantages of doing a chalk talk is that it doesn't have to be exactly the same every time.
Right.
And so it keeps me fresher. So I I have several of these that I do, mainly like on rounds or in small groups. So it's a little hard to imagine doing this with 150 people, but the talk is different every time because I kind of, it's not so much that I find out what my audience wants to know, but I kind of find out where they are and I start there. But I still go back and work on this. I still get to the stuff that I want to cover. And I also recognize that if I don't cover it, it's not the end of the world. That I don't have to give them every single fact that I might have wanted to impart. But if I don't do that, I find that the third or fourth or fifth time that I do it, I feel stale doing it. It sounds boring to me. I can't imagine it doesn't sound boring to the audience at the same time. And that's just, to me, that's one of the advantages. The other little thing I would comment on is if you're going to give chalk talks, I should carry your own chalk.
Yeah.
You frequently run into rooms where you can't.
I always carry dry erase markers with me because it's very common. I don't assume that you guys have it here. I used to walk around with a dry erase board when I did. I used to carry one with me and put it up. When I'm going to give talks in places, like we have a series in geriatrics. There's a geriatric intercession course for I think third-year medical students every year. And we go out to nursing. My group goes out to a nursing home and teaches in the nursing home. I bring a dry erase board with me because now I've developed a thing where it's very hard for me to talk without drawing pictures about anything. Anybody here not do chalk talks? Yeah. Anybody want to talk about or feels that they could be doing more, right? And what are your apprehensions? What have been your apprehensions about doing this?
My handwriting is bad.
Okay.
Yeah, so I do chalk talks, but I really have to concentrate on my handwriting.
Yeah.
And so.
Yeah, it's bad, and it gets worse when you write on a board.
Yeah.
Yeah.
So you can get away. The other thing that I do is I keep erasing the board, but I like the idea of having a scaffolding that you keep going back to. So I'm trying to think about how to keep that scaffolding and then write things on the board.
So if you're in LR6 or whatever it is, or most of the med student ones, it's great because you have this really long board, and so you can almost move across the board and leave a lot more up. In a tight board like this, it's hard, and you have to think about how do you want to. You need to give people an anchor, a visual anchor, to some degree.
And I actually teach a course to the fellows here on how to teach, and there's no whiteboard even in the room.
Yeah. So do you teach it with PowerPoint?
I do.
Yeah.
And then I bought a portable whiteboard to bring in, but it's too small. It just doesn't work as well.
Yeah. So when I have a portable whiteboard, it's usually to do things like draw a human body or draw a brain, like my squiggle brain, right? But you can't do much more than that. Other thoughts about who thinks that they have their areas of interest are too boring to do a chalk talk? Because I would say hyponatremia should be too boring, but somehow, right?
But I could see hyponatremia lending itself really well because there are different categories and subtypes within each.
Right.
So I think it would work really well.
I was just teasing you.
Okay.
Well, sometimes even when I talk about antibiotics or so or levels, I draw a graph. Now then, I'm not sure if that applies, but sometimes it just helps to sort of draw that sort of confinement and talk about the PKPD, and I call that sort of a chart too. And I always draw because I think if you just talk, that it just like flows away. So I think that graph sort of puts everybody people pay attention just because there's some ink on that board.
Who here is concerned about the concept of edutainment? You guys are familiar with this term? Edutainment? Yes, no? Who's heard of it before? All right. Does anybody worry that some of what I'm promoting here looks a little too much like edutainment and is too soft for medical school?
I think it just takes a lot of work. Like you almost have to put it in the same. It's like you have to plan the content, and you sort of have to. I mean, maybe this comes real natural for you, but like for me, I have to plan my jokes ahead of time, or sort of plan my self-deprecation. Like, well, I haven't really got it everything, but so it takes work. It is an additional, that you have to invest in. thinking about, well, can I inject some kind of humor into it that's actually going to help somebody remember something? Because that's also, some teachers are really good at that. And that's like something that, is a trick or something to get them learned. So I don't know, I definitely think at maybe at the medical student level, like to be able to do this is really helpful. And then at the resident level, then I think there can be a lot of judgment, like, oh, they didn't teach me anything. There was I started getting nervous about it. Like,
right.
Or when I teach my fellows, and weirded out by that, I feel like I think I'm just like dancing around.
I agree. I think that the chalk talks are really good when you're trying to boil things down to big picture. It is, and a lot of these tricks are really trying to engage a less sophisticated learner in moving a little bit upstream toward more sophisticated. And you're trying to provide a bridge, right, to more sophisticated information and make it feel like a safe and interesting place to keep going. As you get into fellows and really specialized learners, I don't do really as many chalk talks for really sophisticated people. I do chalk talks for generally medical students, early residents, and people in the community, non-physicians, right? That's where I see a lot of value. But I think if you do small content areas, you can build more detail into it, and that would be something. It's hard to do a survey lecture for a fellow in an area that they already have a lot of exposure to. Yeah. And as far as your, yes, I agree. I think this forces you to think a lot more about how you convey the information, and that becomes a big part of your prep, as opposed to when you're doing a PowerPoint presentation, a lot of your focus is on, what am I going to fill in these slides? I need 4 bullets, right? What's the next slide? And the fact that what students appreciate is the first part, that you clearly gave a lot of thought to how you want to convey this information and their stance as a learner, as opposed to sometimes the drone of PowerPoint,
I don't do this with med students, but I certainly teach residents. I would say you can do virtually everything you are saying, with the exception of actually drawing, using any medium. So I don't know.
I agree.
Everything you're saying is doable.
Yeah, this isn't, that you make a good point, Maman. I was thinking about calling this something more like tips for teaching in general, because I think most of this applies even, and I incorporate this even when I'm doing PowerPoint. I do a lot of PowerPoint talks, but I agree. I think these are strategies for engaging learners and injecting novelty into the learning environment. But it was advertised as chalk talks, so I had to stick with that. Otherwise, I'm sticking with the syllabus, guys. Right? You didn't talk about chalk talks.
So the other thing I think it's a great point that these chalk talks are more geared towards when there's more of a different level of expertise. Sometimes you can have sort of a standardized patient scenario and then do that in the chalk talks. So then you engage a little higher learner and you can make it as sort of subtle as you want, sort of steered by the audience. So I sometimes use that for fellows, because if they know the first couple of questions, you go deeper, and you still sort of put it out on the board.
Yeah.
Yeah, I think for cases.
Do you guys inject some of your own humanity? I know that sounded really weird, but into your talks when you're trying to engage people? I think there's a standard practice where we think we're going to engage the audience we start out with a patient presentation. Like, there's a couple of things we do. One would be to try to engage the audience by showing them the public health cost of this organ disease, right? This costs the United States $7 trillion a year. The problem is everybody says that about their disease. I have a friend who's an OCD expert, and he insists it's the #1 most expensive medicine in the world is OCD, or expensive condition, and it's not. But he believes it is, right? But nobody else does. That's the problem, right? And that's one strategy. I don't think you usually engage people with that. Similarly, patient presentations, it does help, but it's become a little bit of a standardized thing. So-and-so is a 44-year-old, woman with this and this, it may not grab people emotionally. I think where you really grab people is when you talk about your struggle in working with that individual. And so the extent to which you can make that a part of the patient's illness and management, they're going to be more, I think they're going to be more connected to now talking about the disease itself. Wow, you're going for it, yeah. Right. Get ready. It's going to be a horror show. Yeah. Yes. Yeah. And when you talk about this, so I'm just curious, when you talk about decisions you've made that have resulted in really bad outcomes, what's the point of doing that?
I mean, in one way, it was like obviously these cases have been learning experiences for me. So there's like one nugget or a few nuggets of things that will stick with me forever, and I want to encourage that. Don't ignore this, or there's this one little thing that always do the neuro exam, or always do it, whatever. So it could just be something that especially this for a higher level resident, I think works because we start to get really fast, right? We get really efficient, and this is usually kind of the thing I want to leave with people is slow down for a second and do this one thing that we think we're better.
Yeah, you're really trying to inject salience into this point, right? So we're walking around, filtering information constantly, right? And we have to figure out what's salient and what isn't. People that don't do this very well, by the way, are severely mentally ill people, right? They don't filter out irrelevant or neutral stimuli, and they're tortured by it, right? So right now I'm sitting here, I'm paying no attention to this microphone right here, okay? I'm engaging with you all. And I've done a nice job of filtering that, but people say with a psychotic illness, they have aberrant salience, and they attribute meaning or import to things that they shouldn't. And then they are in this really confounding state of trying to ignore something that they shouldn't be challenged trying to ignore. And then they have to construct a whole story for themselves on why this is so relevant. And then the delusion comes as a form of relief, right? Oh, I finally figured it out. I came up with a theory on why this is so important, right? So you're just trying to get somebody to appropriately attach salience to this point and say, this is actually could very well be immediately relevant for you sometime in the next few months, right? The consequences are real.
One of the things that I do, which is a variation of what you said and captures many things, is to talk about how my own thinking evolved and how my teachers were critical of my thinking and how some of my students were critical of my thinking.
Yeah.
And to do many of these things where you are not the expert.
Right.
And I am somewhat knowledgeable now, but I was like you.
Yeah.
And it's kind of a useful technique to show how you thinking about the topic.
Right. The extent to which your learners can identify with you as a future version of themselves is the greater extent to which they're going to be interested in what you have to say, I think. Again, remember, what's every medical student's favorite topic? So if they can project their favorite topic onto you, you're gonna have their interest. Okay, well, this has been a fun time for me. Thank you for inviting me, if any of you did. And I don't know, maybe I'll start showing up to some of these. So.